Hello, my case study is case study 12 asthma, and the underlying disorder is respiratory alkalosis. My name is Paulson Ilekur. Patient case introduction. The chief complaint: patient appear breathless, stating cold getting to me. Peak flow is only 65%, getting worse. History of present illness HPI. DR is a 27-year-old man with complaints of worsening, shortness of breath, fatigue, wheezing, cough, stuffy nose, watery eyes, and post-nasal drip. Complaint I started 4 days ago. I present to the nurse practitioner at the family care clinic. 3 days ago, he started tracking his peak flow rate a couple of times per day. His peak flow rate has varied from 200 to 240 liter per minute, with baseline 340 liter per minute. He stated that he usually get lowest value in the morning. At time he started that 3 days ago, he started self-treatment, repeated use of albuterol inhaler, which he has been doing for a while. He reiterated that although the albuterol nebulizer relieves the symptoms, it's no longer an adequate intervention for his current asthmatic incident. Asthma description and epidemiology in the United States, as shown in the diagram. The asthma disease body in the United States lie lopsidedly on minority, older adults, and people with low socioeconomic status, including blacks, Hispanics, American Indians, and Alaska Native. Highest occurrence, hospitalizations, and death occurs among these groups. Furthermore, while incidence and prevalence are higher among children, there's higher morbidity and mortality among adults. Similarly, childhood asthma is more prevalent in boys compared to girls. Adult asthma is more common in women compared to men, according to the Centers for Disease Control and Prevention (CDCC) 2023. In children, asthma could impair the development of airway and decrease the chance of attaining maximal lung function in the long run. These deficiencies may continue into adulthood despite no additional uh, gradual loss. In adults, asthma may speed up decline of lung function and raise the risk of obstruction or fixed airflow, with more severe effect among individuals with early onset asthma (EOA) compared to people with late onset asthma (LOA). Pathophysiology of asthma at the cellular level. Asthma is a chronic inflammatory disease characterized by airway inflammation, hypersensitivity, and obstruction. The pathogenesis of asthma is complex and involves a variety of the cells of the immune system, including the T lymphocytes, the B lymphocytes, the mast cells, neutrophils, macrophages, eosinophils, and dendritic cells. Disease. Recent studies suggest the prominent role of the dysfunction of the T cells or macrophages, the role they play in asthma progression. There are two phases of asthma pathogenesis: the early phase and the late phase. The early phase is orchestrated by the IgE antibodies, which are created or are released by the plasma cells when they differentiate. These antibodies react to certain environmental triggers, including dust mites, pet allergens, mold, and farm animals, and pendandas, smoke, and perfumes and scents. The antibodies then bind to high sensitivity mast cell and basophils. As a pollutant or trigger is inhaled, these immune cells, as uh, they take these allergens or these antigens, they release cytokines, which are growth factors, and then granulate like the basophil, can degranulate and send their chemicals to communicate with other cells. Specifically, the mast cell release histamine, prostaglandins, and leukotrienes. Moreover, the combined actions of these cells and inflammatory mediators lead to smooth muscle contractions and eventual airway tightening. Th2 lymphocytes play a crucial role in the production of a line of interleukins, interleukin 4, interleukin 5, and interleukin 13, and granulocyte macrophage colony stimulating factor, which is a growth factor, BMCSF, that extend communication with other cells, other cell types, and thus perpetuate inflammation and bronchospasm. Interleukin 3 and interleukin 5, they sustain the survival of eosinophils and basophils, while interleukin 13 aids in the tissue remodeling, fibrosis, and aplasia. The interleukin 3 send chemical messenger to interleukin 3 and interleukin 5. They send chemical messenger to eosinophil and basophil not to commit apostasy or cell death, to continue to survive and perpetuate these inflammation and these bronchospasm. And within a few hours, the late phase begins with the migration of eosinophils and basophils, neutrophils, and helper and memory T cells, the lung sites where the inflammation is taking place, leading to bronchoconstriction and further inflammation. The late phase modulators are ushering into the inflamed areas, as I said earlier, by the mast cells. The result of the inflammation and bronchoconstriction, intermittent airflow obstruction, are leading to increased work of breathing. Airway hyperresponsiveness or hyperactivity or hypersensitivity is a hallmark feature of asthma, which is an excessive response of bronchoconstriction, typically to a variety of stimuli as said earlier. Also, there are different mechanisms that result in airway hypersensitivity or hyperresponsiveness, which includes increased histamine release from mast cells and increased mass of smooth muscle in the airway. Other increases include vagal tone increase and intracellular free calcium increase, which further amplify the contractility of airway because calcium release or calcium gate is required in contraction of smooth muscle cell. Clinical manifestation: pertinent subjective data. Complaint has been stated before. Patient appear breathless. He's saying cold getting to me. Peak flow is only 65%. Getting worse. Issue of present illness HPI. As it has been said before, is a 27-year-old man with complaint of worsening shortness of breath, fatigue, wheezing, cough, stuffy nose, postnasal drip that started 4 days ago. He presented to the nurse practitioner at the family clinic. 3 days ago, he started tracking his peak flow rate, and a couple of times daily. His peak flow rate has varied from 200 to 240 liters per minute. His baseline 340 liters per minute. He has a lowest value in the morning. At the same time, he started self-treatment with albuterol inhaler, which has failed. That's why he presented at the clinic. Past health history: was born 6 months premature related to mother-intestinal infection. He spent 2.5 months in the NICU. The mother discharged 2 weeks prior the full gestation period originally. He has asthma diagnosis at age 18 months. He has persistent moderate asthma from age 19. He had 3 hospitalizations last 3 years with 2 intubation related to acute bronchospastic. He had two emergency room visits in the past 12 months, and he also has history of 15-year perennial allergic rhinitis. Family history: both parents they are alive. 51-year-old mother with history of cervical cancer and partial hysterectomy. He has 50-year-old father with history of perennial allergic rhinitis and pet allergies. Probably his asthma is related to that he inherited from his father. Social history: no use of alcohol or tobacco. Is married with 2 biological children and 1 stepson, 3 children altogether. Is a college graduate, degree in business, currently working as a business development consultant in a private firm. No pet at home currently. Allergies include grass, ragweed, and cat. Cat causes sneezing and wheezing. Medication include a propionate bromide, meter dose inhaler, 2 inhalation twice per day, triamcinolone, which are corticosteroid, meter dose inhaler, 2 inhalation twice per day, albuterol meter dose inhaler, 2 inhalation every 4 to 6 hours as needed. Pertinent objective data: physical examination, vital sign, blood pressure 150/80, respiration rate 24, pulse is 115, temperature is 100.2 Fahrenheit, his current weight is 220 pounds, pulse of paradoxa is 20, pulse ox is 92% room air. Increase, the following have increased: dyspnea and agitation. Pulse is 125, and repeated pulse is now 125. Repeated pulse paradoxa is now 30 millimeter mercury from 25. Respiratory has increased to 35 now per minute. With labor breathing, is now wheezing with loud inspiration and expiration. Early sign of cyanosis is now evident. It's cold and clammy body, and his extremity is also clammy and cold. Loss of alertness and orientation. Diagnostic tests include laboratory blood test, sodium 139 milliequivalent per liter. His hemoglobin is 13.6. His monocyte is 6%. Potassium is 4. Hematocrit is 41%. Eosinophil is 30%. 3%. Chlorine is 105. Platelet is 292. And bicarbonate is 26. White blood cell is 8.9. Calcium is 8.8. BUN is 15. And magnesium is 2.5. Creatine is 0.9. Band is 2%. Phosphorus 4.1. Glucose, blood glucose, non-fasting blood glucose 104. And lymphocyte is 37%. Peak flow is now 175 liters per minute. Arterial blood gases now pH is 7.55. The oxygen, arterial partial pressure of oxygen is 30 millimeter mercury. The pressure of arterial oxygen is 65 millimeter mercury. X-ray is amphilated lungs with no infiltrate, severe inflammation and pneumonia. The role of advanced practice nurse underpinned by the Christian world view. Since the patient clinical style is deteriorating, getting worse, despite current treatment, as evident by the increased pulse paradoxa, which is now 35 millimeters of mercury, loss of alertness and orientation, worsening physical examination, poor arterial blood gas parameters, and critical signs of early cyanosis. It is of crucial importance that the APRN make pertinent recommendations, which include intubation, mechanical ventilation to prevent respiratory insufficiency or failure, and intervention to correct acid-base imbalance. And further evaluation and monitoring must be conducted of ventilatory status and vital sign. Stability. The APRN will also continue to analyze the arterial blood gases for imbalances and to report the critical results to the provider. The APRN will also advocate for renewed focus on managing acute symptoms, but not only that, also the chronic respiratory and clinical outcomes. The following questions are proposed. Do the patient arterial blood gas determination indicate that the asthmatic attack is mild, moderate, or bordering on respiratory failure? Number 2, we have to identify the metabolic state reflected by the patient arterial blood pH. Number 3, what is the cause of this metabolic States. And thank you. The references are there.